Welcome to another edition of Off Limits. Our guest today is Dr. Sunil Chandy, a well-known cardiologist, a good voice on healthcare. He is the Chief Medical Officer with ITC now, but we have known him for a long time, or of him as the former director, now the former director of the Christian Medical College, Vellore. Thank you so much for joining us, Dr. Chandy. It's a pleasure having you with us.
Thank you. Thank you so
And
much. Yeah.
well, I'm going to start with something that I think you've spoken about and written about, perhaps, about healthcare, basic healthcare with us in India. Uh, we've always, as journalists, seen that one of those politicians who's pretty low in the hierarchy is made the Union Minister for Health by all governments. Not today, not yesterday, but from time. This itself sends out a signal that healthcare is not in the list of priorities for governments in India, and also that healthcare's budget itself speaks for this. What do you think about this?
Yeah, so the two aspects, let me take the second one first. If you look at the public health allotment from the government, it used to be 1.3, but I think in the recent budget, they have upped it to about 2.1. Well, that is still a lot less than what it should be for a country of 1.4 billion people. And if you look at how they manage it in other countries, there are some countries which has got almost 9%, 13% of their GDP allocated, apportioned to healthcare, mainly public health. And those are all countries which are much smaller than us. So I guess the absolute amount of money that's rolling into healthcare is much less. There may be political concerns, but I agree with you that for the kind of pathology that we are seeing in India, have seen, a triple disease burden where we are not only fighting the age-old communicable diseases, but there's an enlarging number of what's called NCD, the non-communicable diseases. Right. And with the COVID experience, there's a third dimension that's come in, which is much shorter, but very, very intense, like the COVID pandemic that we had. Yes. Which has created a new layer of epidemic-related disease. So it's actually described as a triple disease burden. It used to be dual disease, now it's triple disease. And for all the different aspects of healthcare that's emerging, not only the problem, but also the solutions. Public health is still not attended to in the manner in which it should, and it can only be attended to by a much larger apportioning of the national budget onto healthcare, and primarily focused on primary and secondary healthcare.
So when you spoke of epidemics, and you said of this third layer, I mean, you'll have to explain it a little bit more for the layperson. Yeah. But we as journalists, and I'm sure everybody else, you as a doctor, would have seen these epidemics across in our rural areas of gastro and cholera and malaria, and it's all seasonal and it's awful. It just sweeps across villages.
Yes, that's true. So this third layer is created by this unprecedented, unexpected COVID pandemic. And the pandemic commenced in March 2020, and it's still going on in one form or the other.
Yes.
And the truth is that the COVID pandemic is now COVID endemic. It has come to stay with us in our colonies, in our residences. It is not going to leave the planet. We will have to consider this as an unfriendly neighbor, which we will have to deal with public health measures, vaccinations, etc., etc. And certainly, India has done very well in having tackled this massive pandemic, which at the second wave created such a turbulence. But with very systematized method of vaccination, Things have improved. There's a herd immunity which has built up. Vaccination coverage has been pretty good. And therefore, we seem to have kind of, I wouldn't say conquered, but we have come one-on-one with the pandemic. But
Right.
what the pandemic actually tells us is that this is not the first and the last pandemic. There will be other pandemics, not COVID, but we've also had minor problems like the Nipah virus, and now we're facing the monkeypox. So what COVID pandemic has done is to raise our antennas to the possibility of similar viral and bacterial epidemics that is yet to come. And that can only be tackled by a general preparedness of a pandemic situation. It's something like disaster management that we practice for earthquakes and tsunamis and all that. Likewise, there is a tsunami of healthcare problems that may come. So a national preparedness is what. So that's the third burden that has come in. So it's at a national level that we need to be very, very vigilant and have our systems in place so that if it strikes us, we are much better prepared than what we were during the COVID, because that was just too overwhelming and too massive. It caught us napping in one sense. And it all kind of converges onto the public health segment of healthcare.
Exactly. This point of it converging on the public health sector system or the state of our public health is extremely important. Now, this third layer is obviously, from what the examples you've given, is obviously global in its impact.
Yes.
And because it's global in its impact, it also impacts on the middle class, the upper middle class, and the rich. But what about the epidemics that continue nationally? And we have not been able to control them, it seems.
So, that's a good question. That takes us back to the first burden of what it was, decades and maybe centuries ago, where we didn't have much of heart disease or diabetes. It was there, but much smaller. It used to be cholera, tuberculosis, malaria, kala-azar, filaria, so on and so forth. Now that, unfortunately, while most Western developed countries have conquered, we have not been able to completely eradicate that. Yes, we've eradicated smallpox. We've got vaccination cover for things like chickenpox and diphtheria and all that. But we do hear of outbreaks, you see. And those kind of diseases, by virtue of its biology and pathology, tend to be focused on the lower socioeconomic strata, which is largely in the hinterland of India. And that is why we occasionally hear a Japanese encephalitis, mosquito-borne disease, and dengue fever epidemic, which basically will come in a small geographical area of a state. It will peak, it might kill a few people, and then it subsides. And then again, seasonally, it comes on in another part or another part of the year. So this problem continues to exist despite vaccinations. And again, it points to the non-medical determinants of such diseases. For example, mosquitoes. The mosquito control should be relooked at. Sanitation. Yes, there is a Swachh Bharat sensitivity, which is excellent, but a lot more needs to be done. And, it is not just about medicines and injections and lectures on high-tech medicine, but there's a huge gap which has to do with the social and economic determinants of disease, the first layer. So there has to be a completely new movement into the rural areas and even the urban areas, which are the slums and all that, to raise this level of sanitation and sensitivities to things like vaccination and preventive care. So unless that is done, we'll continue to have a triple disease burden.
So once upon a time, when we all entered journalism, and that was during the print era, we all cut our teeth, all were made to cut our teeth on covering rural healthcare, on covering healthcare per se, and pointing out what was going wrong. Of course, now you don't see it in the media at all. But there was this whole scheme of barefoot doctors, which was compulsory. People resisted it, but then people did go to the villages and work there. This whole thing, do you think there should be some kind of a revival of all this commitment to rural healthcare?
Yeah, absolutely. So, it all started well, I guess, where the disease burden was primary communicable. There was an equity in rural and urban healthcare. But things have changed over the last 30, 40 years with private healthcare coming in, which was mainly focused on specialty care, on tertiary care, and urban care. And therefore, what has happened is the consequence of that is that the new generation of doctors who are coming out are less exposed to the real India. By virtue of their training, even, how many of them go to the villages during their medical school, except for compulsory postings, which is very cosmetic? But to get into the heart of the hinterland and say, yeah, this is where the problem is, and this is where I need to be. So there is no motivational, initiative from the system itself to expose medical students to the hinterland where maximum number of people reside. More than 60% of the population is in the hinterland, in the rural India, whereas they have only 20 to 30% of the doctors there. And it's the reverse, where you have 70% of the doctors attending to 30% of the population in urban. So you can see the skew in this whole equation.
Yeah.
So, well, that's one aspect. The second aspect is today's medico. You ask him what is his motivation to go to a rural, isolated, remote setup. Nothing. Life is difficult. There may not be electricity, water, facility. Will a doctor couple go with children? Where will they school? What about security? What about indemnity? What about their long-term career prospects? You see, these are all the necessary beads of the necklace of somebody's rural-oriented career. And the system doesn't support it. It is all focused on urban care, high-tech care, artificial intelligence, all that looks, like a glimmer. And that is what attracts people, and it's but human nature. Who would want to go to a forest tour? So it is incumbent on the medical leadership, the medical fraternity, the education, the pedagogy of medicine, as well as the government to say that, look, there is an incentive to work in the rural area. We will take care of you. Your career, your plans, your salaries should match the salaries of the people sitting in private. That's where the larger allotment of government should come in.
Right.
So it's not, I believe that commitment and motivation is a two-way street. Those days are gone when you could say a speech and inspire young medical students. They want to see role models, and they don't see any. You see, it's all big talk in journals and magazines about an isolated person who's done yeoman work, and we clap hands and applaud him. But will you go? No, because life is hard. You may get killed by a wild animal. You may yourself suffer from these communicable diseases and die. What's the backup? So I'm coming down to practical brass tacks, stepping down the ivory towers of medicine to actually see that this is the challenge. And this is why COVID strikes. And this is why malaria strikes. And this is why now even communicable diseases is striking the villagers, because they are role modeling on the fast food and junk food that city dwellers are eating, and they seem to be doing very well. So it's the entire thing is a melting pot of a huge medical problem in 10 to 20 years' time. We are still far away from the SDG goals of the World Health Organization, far, far away. And our trajectory, I believe, is not quite right, in wanting to create a model. Yes, Ayushman Bharat is attempting a lot, but there are gaps, let's face it. There are gaps of reimbursement, of committed doctors. I, for one, believe that no technology can replace the gaps that exist today in Indian healthcare. You need people. You need committed doctors. You need young people. And it's not enough to say, go. You have to inspire them. by role modeling and giving incentives that there should be a rural compensation package. That if I spend 30 years of my life serving the people of my village, my rest of my time when I retire must be taken care of. I mean, let's face it, it's difficult, but that's really the truth.
Right. And I think this whole thing of public health, of rural health, and health infrastructure. I mean, today I know All India Institute of Medical Sciences has acquired some kind of a political complex because of political parties, but then that was one of the institutes. One is the kind that you were working for, and they're just little pillars of excellence. And outside AIMS in Delhi, you can see millions of people coming from the rural areas, and they obviously are coming at their last stage because they've tried everything from quacks to whatever is available in the rural areas, and then coming
Yeah.
out here and living on the streets and hoping for some attention.
Yes.
This, this kind of pressure also on the
Yeah.
doctors, on the health system. So, how do we alleviate it? Of course, you've suggested a lot of things, but like in sheer economic terms, what is the kind of budget that is required to build a good, solid health infrastructure?
Uh,
Ideally,
this yeah, no, this actually takes us back to the first question, the first part of the first question on what is the medical leadership like.
yeah,
I personally believe that the government must re-envision healthcare because a lot of things have changed. It's not about creating some programs like digital mission, and those are all the operational aspects of it. But to answer those basic questions that 75 years down the line, who are we, what is our medical legacy, and where are we going? You see, this has not been answered, this has not been tackled. And that largely comes from the political system, not this government alone, but even the previous government. Who makes the policies of healthcare? There's not much of medical input into that. See, it's all operational, bureaucratic, systematized, protocolized. That doesn't work that way. It works for a factory. It works for a manufacturing system. It doesn't work in healthcare because healthcare is nuanced with a lot of soft things, emotions, the affordability, the accessibility. So if policies are drawn up, just based on inputs from digital vendors that they will revolutionize medicine, and I keep writing about this and speaking about this, that those are bridge systems that are only complementary.
yeah,
It itself cannot become the soul of healthcare. But unfortunately, the messages that we see is that here it is, move over, doctors, digital is taking over. I'm sorry, that's not going to happen.
yeah.
And when we realize this, after a lot of time has gone, it will be too late.
Yes.
You see, so you need to have medical people. If you ask me, the health minister must be a medical doctor or a nurse. You see,
Absolutely.
because they know the deep cuts of medicine, they know the soul of medicine. And then you must have the next layer of people who are operations expert. Okay, this is what I want to do. Now, how do you do it? Now, you tell me. You see, so there's a huge gap in the fundamental philosophy of which way we are. Should we ape the West? I don't think so, because our problems are different. So there has to be a complete recalibration of the fundamentals of healthcare.
Right.
Who are we? Where are we going? Where have we come from? So that I think is the reason. I agree with you. If I were to make a decision, I would put the health minister as a person who's central to human medicine.
Absolutely, should be. Yeah. So I'm going to shift a little bit, obviously, to an area which you are known for and are taking a great interest is trauma. In considering the kind of accidents and the number
Yeah.
of accidents and fatalities and the amount of people who are getting injured just by being on the road.
Yeah.
And most places are finding it difficult to deal with this. I know AIMS set up a trauma center and it's
Yeah.
now jam-packed all the time.
Yeah.
So, is this another area and an important area which impacts on everyone from the richest to the poorest that we have ignored?
I mean, it's a strange coincidence that we are talking about this just 3 days after a celebrity had a road traffic
Yes,
accident.
exactly.
But there's no reason for that to have occurred if the entire trauma prevention and trauma management system was a little more seamless and smooth. Unfortunately, it is not. Trauma, especially road traffic accident trauma, mortality, is now a significant part of NCD. When we loosely refer to NCD, we always allude to diabetes, hypertension, heart disease, psychiatric illness, stroke. Yes, they form the chunk, but there is also this segment of a non-communicable disease entity which is related to modern lifestyle road traffic trauma, which is a significant number, not just quantitatively, but also qualitatively. Because we must understand that when an earning member of the family is lost in a road traffic accident, there is also a social impact of a family that is now penniless, of security, of children's education. I mean, you throw that impact of that trauma death down the line 20 years, and you can see the struggle. So there's a qualitative deficit also. So this is the truth about, and I feel that this is a totally man-made because there are countries in the world which have completely mastered trauma. You know, in a particular state in Australia, they had to consider shutting down transplant programs because they could not get organs because there was no accident. You see, I mean, it's bad for the transplant surgeons, but you can see how they developed, and it was all basically an approach rather than the roads or the addition of vehicles. They were also adding roads and vehicles, but the entire ecosystem was designed in such a way from prevention to care that there were a road traffic accident was looked upon as something extremely unusual and an aberration. Whereas we are in a system where it is routine, it is so routine that we don't even bother till a celebrity becomes a victim.
Yeah.
So yes, it is in futuristically, it is going to occupy one of the significant components of non-communicable disease mortality and morbidity, both. Not just death. Imagine somebody who's lost a leg, somebody who's become a paraplegic. The socio-economic impact of such an event, totally preventable, is huge.
So, when you said about the celebrity we are referring to, that it could have been avoided, what did you mean by that? I mean,
So, I mean, see, avoided in the sense, I don't know the details of this particular event, except that such a thing happened. But going by what we see on our roads in our normal sphere of life, is that I believe that some of our highways and roads are the best in the world in terms of structure. The way it's been laid, the laning and the beautification, and it is certainly one of the best, if not the best. I've seen roads in other countries. It's very well maintained, and now there's a network of roadways crisscrossing the country. All that's very good. We're now getting on to a toll gate management, etc., etc. But I think we still have a problem of escalating number of deaths, basically because we do not have the required culture of road management. By this, I mean, the civic sense in the public, the enforcement of basic traffic rules, the requirement of immediate and aggressive post-accident care, that whole ecosystem, which should be run by the highways. That is what leads to mortality. I mean, you also drive, we drive in cities.
Yeah.
We can see the total lack of traffic discipline. And that is the reason for 85 to 90% of the accidents. You know, civic sense is poor, there's no lane discipline. I find it difficult to now see, we always look at your right side for people overtaking you, but now the overtaking is from the shameless overtaking from the left.
Yes.
And as they overtake you, they will look back and curse you for being on the right side.
Yeah.
You see, honking, blowing a horn is done for emergencies, but blowing the horn is like a siren in, hey, I'm coming, move out. I'm coming at 120 kilometers, move out. So there's going to be, and some of those horns are medically unacceptable in terms of its decibel levels, in terms of its irritating cadence of, you know, like that. So there's no control. There are buses that will decide to park right on the middle where they are without giving way. And there's a buildup of traffic. This pavement encroachment by shopkeepers. So where do the pedestrians go? They'll spill onto the road and get hit. There's no separate lane for bicycle people, where bicycle transport is now being popularized all over the world for its pro-health and pro-environment reasons. But there is no cycle track. It's dangerous to cycle on the road. Road rage is rampant. And there doesn't seem to be any kind of discipline enforced. You know, the old traffic policemen seem totally helpless standing there because they're totally overwhelmed by a lack of discipline and a lack of system. And there's no demand on them to enforce discipline either. So that's the reason why road traffic trauma is huge in our country.
And you know, you're suggesting, or what you could contribute and are contributing, is in terms of just the medical component, right? Which is a very important part and an important part of that ocean. But now when you put it the way you have, then we are talking right from the issuing of driver's license.
Absolutely.
License without corruption, to traffic enforcement, to discipline, and then also after the post accident, also looking after in medical and psychiatric counseling for the relatives, survivors, victims, whatever. So it's a holistic thing, right? And it's pretty big.
So, you know, there are three components to trauma care, which we have learned. I'm not a trauma specialist, but this is what I've learned leading it. One is the life-sustaining intervention, that, okay, there's an accident, unfortunate. Within an accepted time limit, there's an ambulance that reaches there, which is not just a transport vehicle. So you see, the concept of ambulance care has to change in India because of traffic reasons. The ambulance is not a high-speeding traffic transport vehicle that takes you from the spot of the accident to the hospital. It is a mobile hospital with the necessary trained basic life support personnel and the basic equipment, where the aim is to attend to the victims of the accident on the spot. Okay? Absolutely. Why? You want to make sure that life is sustained. That's the priority. You know, blood loss, arrest it. Heart rate, get it going. Make him stable enough to be transported to the nearest hospital. Then it becomes a transport vehicle at normal speeds. There's no need to cut across median, because you've already restored his life, and now you are taking him to the next phase, which is like the one was life-saving. The first one was life-saving. The next is limb-saving. That there will be fractures, you know, the doctors will come and attend in a calm and tranquil manner, put the right systems in place. And the third phase is restoration or rehabilitation, where there's a prolonged period of getting back to the social functioning and socially productive lifestyle that the person needs. So the trauma care ecosystem must evolve that way. And I think our roads are big enough for helicopters to land. Our hospitals now, at least in urban centers, are big enough to have helipads either on the top or on the ground. So, this kind of a rapid transit system, after you've restored life, saved life, to limb restoration and to rehabilitation, must develop in that manner. Okay. So this requires the input of medical people, trainers in emergency medicine, the advanced cardiac and the basic life support system personnel. They can be paramedics, special nurses, trauma care nurses, and a 3-tier system in the nearest hospital. And the government should take a survey and see that, every 25 kilometers, there's a basic trauma care setup. Because we are such a huge country, you can't travel 200 kilometers to the nearest trauma center. You see, that's why we lose.
So we are really, the journey sort of began perhaps earlier on and it's been stalled since, right? So the last question, Dr. Chandy, what would be a good effective budget to look at healthcare, or at least start, bring the journey back on track again?
So, see, I'm not a numbers person and, I don't want to even guess. But what I feel is that the best way to handle this is to 1.3 to 2.1 is almost a double of, if that apportioning is, it's a good start. But it is largely focused on things that are not towards trauma care. So I'm suggesting that trauma care and NCDs be given a special niche in the healthcare platform. And there should be a separate budget that is focused on public health, which is basically rural healthcare, including trauma care. Okay, a special budget, which can be calculated by the economists to see in the length and breadth of the country what is it that we can do to design. First, it's design a basic setup which will take care of these 3 aspects and have a referral system to higher centers which are specialized in doing all the special surgeries and special rehabs that are needed to do that. Right. So I would leave it at that. But if you just ask how much should the GDP health budget should be in India, my guess, and I'm not an expert, it should be 5%. If we want to do some justice to the healthcare scenario country and putting it into one basket, 5% would about make it. I don't believe PPP will work because between the first P and the second P, there is a diversion of the outcomes. It is not one is for profit and the other is for service. Right. They come together for business collaborations, but it will not work because your philosophy is completely different.
Completely different. Yes, absolutely. In fact, confrontationist as well from one end.
Yeah.
And thank you so much, Dr. Chandy. It was a pleasure.
Yeah, thank you.
With us.
Thank you.
Thank you.